regards to you. Can you hear me now? Fine.
Yes, I can hear you loud and clear.
Okay. So, on behalf of Supreme Knowledge Foundation, our sincere thanks and regards to you for accepting the invitation. I know that you are for a very important reason in abroad. So, we are thankful to you for taking time out from your extremely busy schedule and then to interact with all the attendees. We are having approx 50 professors across different colleges who will be listening to you. And it's an advance invitation. Next time when you will be in Kolkata, we want you to be in our campus and to interact with the professors and the students. Without further delay, as you are very busy, so I am just handing over it to one of my colleagues, Professor Siddhas Bhattacharya, who will be the moderator of your session. Thank you.
Thank you, sir. So, good evening all and welcome back to the Day 3 second session to the program AICT Training and Learning Faculty Development Program on AI for Healthcare Excellence, Innovation Challenges and Future Trends. So this 6-day academic journey is a forward-looking initiative sponsored by AICT aimed for fostering academic and industrial synergy in one of the most rapidly evolving domains, artificial intelligence and healthcare. So today we are actually very much fortunate to have Dr. Sujoy with us, who is very much engaged in the digital transformation of Indian healthcare. So please allow me to introduce the speaker before this session. Dr. Sujoy is currently the Chief Medical Information Officer and Vice President of Apollo Hospitals, India's leading integrated healthcare provider. He previously served as the Medical Director at Apollo Gleneagles Hospital, Kolkata. Dr. Kaur brings a rare combination of clinical expertise and healthcare management and technological foresight. His work at the intersection of clinical, medical and artificial intelligence has inspired many digital health initiatives across the country. We are immensely honored to have him share his insights today on the topic AI-driven telehealth opportunities and challenges. With that, I would like to invite very warmly Dr. Sujoy to lead us through this his enlightening session. Sir, virtual floor is yours.
Thank you so much, first of all, for inviting me to your institution. I will not be able to, I'm not able to come in person, but I thought when Dr. Sarkar had asked me to, present, I said I must not lose this opportunity to at least address all of you in in coming over and doing this. I need a permission to share my screen. Can someone give me the permission to share the screen, and then we can just get quickly done. I won't take too much time today. I just going to spend about 20-25 minutes with you in terms of just conceptually tell what exactly I'm doing in the field of AI in healthcare. And as I speak, I'm in Singapore at the moment, on a particular work assignment for the Ministry of Health for Singapore. We had 3 days of workshop, and then tomorrow I'm speaking at opening keynote for their conference. But these are not the slides that I'm going to present in the other conference, and I'm not doing a rehearsal just by going through here. I just wanted to say that these are exclusive slides that I prepared for your talk, and therefore wanted to keep it in that way.
So you can share your screen. Yeah.
Yes. Yeah. So first of all, thank you very much for giving me this opportunity to address all your faculty at the SKF institution. I'm going to give you a little perspective of what we are doing in digital health and AI. Of course, along with what I do at Apollo, I'm also a professor at 5 institutions, if I've currently counted them well, including Calcutta, IIT Kharagpur, University of Leicester, and then University of Monash possibly, and then of course at the Apollo University as well. I'm also the co-director for the Center for Digital Health and Precision Medicine at Apollo, and also the regional lead for MIT J Clinic in India. So these are some of my current work profile that I do, apart from being the CMO of Apollo 24/7 and Apollo Hospitals CMIO. But if you look at the crux of what we have been doing is guided by the mission statement of the institution and vision of our respected chairman, Sir Dr. Pratap C. Reddy, Padma Vibhushan, who about 5 decades back had the vision to give us a mission statement which was to bring healthcare of international standards within the reach of every individual, and our commitment to the achievement and maintenance of excellence in education, research, and healthcare for benefit for humanity. And we understand that these are very important goals, or these are very important objectives, particularly when you see healthcare or health equity as a global challenge. If you want me to go about in giving you the definition of health equity, it is about what is the absence of unfair, avoidable, remedial differences in access to care. Are we able to give the access to care in the right people at the right point of time with the right kind of cost? And that is something that you have to think it from a global perspective. In India, most of the private hospitals provide the care which is at the 1/10 of the cost that you see in the United States or European countries and others, or even for that matter, much lesser than the cost that I'm in the country that I'm currently in. And therefore, it is very important that, and with very high excellence. So it is important that, for a healthcare organization to actually be on the pursuit of that goal in terms of priorities that are usually entwined with the human rights and social justice, and of course the economic development. But then one of the things that we see, particularly in getting the health equity perspective, is to see whether the health data from public and private organization, including particularly in India, how they are going to overcome bias, particularly ethnic bias, geographical bias, temporal bias, socioeconomic bias, and how do you then ameliorate those biases in building, your solutions that you have to do. The other very important thing that you would have to consider in this is that there is a lot of what we call as the smartphone or the internet divide. There are, almost 33, 1/3 of the world's global population where you would not see them having the access to internet or the smartphones. So if you don't have that, how are you going to even build what we call as the digital literacy? How are you going to answer certain questions around trust and privacy? How are you going to have questions around, diversity and inclusiveness? And it is not just an Indian phenomenon or something that you need to see it from your local needs. It's a global need, and you would see this in every country, wherever you travel. Even in affluent countries, you would have those kind of divides that are now coming in. Now, when you see those divides, and the divides that you see it in the perspective of artificial intelligence, is then the AI in healthcare, particularly then that the gap that is there, is that widening further, particularly, coming from the algorithmic bias or the the fairness that comes out from the way you use this data or build models around it, and how do you then go about in collaborating for the accountability within your systems to do that. So I don't have answers for all of these, but I want your faculty to think it in that way, in terms of when you are building solutions or you are teaching around this to your students, how do you bring in all of these aspects in the terms of care or in terms of how you go about in building the solutions. Now, when we call about building the solutions, the typical steps of building the solutions at Apollo starts with the phase of ideation and then moves on to look at the available data and the process of data engineering. And at what we have been able to do at Apollo is to actually take consents around this data at the time when we are collecting them, and then go about in using very robust anonymization protocol. One of the work that we have done in the anonymization protocol is coming out in one of the IEEE paper, we boast of having anonymization protocol which are better than the publicly available, either from Microsoft, Google, or John Snow Labs, or other labs as well. So it's very important that you build those structures around the anonymization, clinical entity recognition, disambiguation, assertness, relation extractions, question answerings, the whole NLP pipeline. Because once you've figured out your NLP pipeline, you then can have what we call as differentiated databases. And that differentiated databases can then build anything for you in terms of, whether you want to make annotated images, whether you want to do it on the other level data, structured or unstructured data, and then go about in a maturity framework in the data, particularly beginning to do it with something like very simple data models to look at it at a mature data models. And we see these three-dimensional data models in the work that we do. What is this three-dimensional data model? Some other day, some other time, we will discuss about this. The next phase for us is to actually look at it from ethical approvals before we go about in doing this modeling and use this data. So once we have the ethics approval, we would go about in doing the the initial modeling, get the results. Of course, the performance for any models that you build in your own data are going to be very strong, robust, and you would need to have all of those appropriate statistics around your performance, starting from a simple AURC, but looking at your F1 scores and precision recalls and others, and then look at it from a clinical perspective when you are seeing it in sensitivity, specificity, likelihood ratios, predictive values, net reclassification index, and more we use what we call as Matthew correlation coefficient, particularly to see if solutions are clinical grade or not. And then move on to do external validation. And when we do about external validation, that's where you go about in different countries worldwide, take your algorithm and then go and sit on top of the data to do that. And we have been able to build those solutions in terms of what we call as the confidential computing clean room. That's one of my research with Microsoft that I have been doing for almost a couple of years now, in order to actually see how those computing, confidential computing can work on something like, EMR data or images or even high volume streaming or high velocity data that we're looking at. And then go about in doing publications, API generations. Once the API is done, then move on to build what we call as your, go for your certification and then distribute your APIs for prospective use. And that's particularly when you do this, one of the things that you need to do is to go for quality certification of your algorithms, not only within India, but also looking at the different parts of the world, including at this point of time, we have it for Australia, Brazil, Canada, Japan, and many other countries that are co-signatory to this. But at the core of it is the responsible clinical AI, particularly in developing trust that bridges from algorithms to patients through clinicians, and that trust that has been built on consents, considerations, privacy, and confidentiality. In very simple terms about, nothing about me without me is that, you will not be able to go about and use the secondary use of data without knowing what is the purpose of the inclusion-exclusion criteria that you have gone about in, developing a particular protocol. The other perspective is to actually look at one of the papers that we have on what we call as the EASE framework, published about 2.5 years back, 2 years, 3 months back, where we bring in about the ethical consideration, adoption, suitability, and explainability. And in ethics, particularly if you see it in safety, non-maleficence, accountability, which are nothing but medical ethics itself. Because the core of it is the medical ethics that you bring in, then the AI ethics around the efficacy, accuracy, and integrity of the models, fairness and inclusivity, which is particularly to look at it from a bias perspective. And then the adoption. So you have to keep the final thing in mind that some people will be using around it. So what is the relevant outcome? What are those C statistics or the other statistics or performance measures that you think needs to be at good way? Then the suitability part of it, and I talk about a lot around addressing the bias, particularly using fair learn and other equalized ratios and other equalized odds and others to actually see how you balance your models in different population. But one of the key attributes here is to see how you begin your policies around human-machine conflicts, where a human does not believe what the machine says. And therefore, what that could arise in a clinical dilemma or a question that comes in, and how do you go about it using governance frameworks for that. Explainability, and this has happened over the last weekend, a very good paper that has come out in computer science, particularly from an organization called Mila in Montreal, again from Professor Joshua Bengio. I'm sure you know his name, one of the leading writers about deep learning. And Joshua Bengio's team came about in talking about explainability, and they say 3 things. And all these 3 things were there in my paper 2 years and 3 months back. When he talked about verifying before deciding. He talked about building trust in systems. He talked about counterfactuals or causality frameworks that needs to be determined. And I see that all of those things are now in his paper, which we talked about in explainability perspective. So in many ways, that's a validation of our work that we have been doing when it comes from somebody like Joshua Bengio in terms of this. So very important that we build this pipeline of trust, including looking at regulation, workforce, health systems and all that. And I must say, a lot of people across the world are facing the similar challenge, but they are working on it. How you are working on it and how you are teaching this to your students will be very, very keenly seen, particularly, when you are looking at, how the science is moving, our technology is moving in places like Singapore or places like London or in Canada or in US. So it's very important what the kind of things that you're going to go about and talk to your students about, how you move around in doing this pipeline of trust. This is what I was talking about in terms of the next gen data privacy and computing in terms of clean room. This is a model of canonical systems where the data resides where it is, and we do the computing on top of it to get the results in that way and go about in fine-tuning or even building models. And now it looks fantastic on the electronic medical records, but with the higher fidelity of data, particularly in terms of, or higher general data in terms of images and videos. We're still testing it out and seeing how it is coming out in that way. Now, when you go about enrolling AI in healthcare, you would see a lot of challenge, particularly in heterogeneous perceptions, understanding why we should go about in using this, because different group of people will see it different way, and it's important that you begin this conversation, take into different consideration, prepare details around how effective this model is and what that you can go about in doing this, including what is the utility of these models in the clinical use. But then one very important aspect that you would always have to look at is that do not go beyond the intended use of a particular algorithm that you have built in. That is a very, very important perspective. If you have built in to actually an algorithm to predict a cardiovascular risk, do not extrapolate that and say it can also do that for stroke. Though we know that both are vascular events, but what works well for heart does not necessarily works well for brain. So you would have to then do the similar rigor of taking that data, doing that entire process, going through all the 9 yards that I have told you before you get or reach to that. Many organizations, startups don't do that, and they fail. And that's why one of the things that you need to instill in your students is this, that you have to keep the outcome in mind. You have to set why you are developing this protocol and remain true to it. You cannot just go about in changing your goalpost all the time and say with similar input we can do a lot of generalizability. And that's the problem I see in a lot of language models these days. And that's why the question comes how effective the generative AI is, how you process clinical data to identify patterns, predicts, and all of this. Some of my work at this point of time is actually working on diffusion models to actually build multimodal fusion models to actually go about in doing the do the work. But then the primary area that you would have to look at is this, that many of these foundational models require appropriate curations from the authoritative sources to actually give you the correct results before they are clinical grade or they can be used in clinical setting. We've been using this for, say, tumor board or transplant board or summarization for discharge summaries and all that, and have been taking into that. But all of these can bring one definite questions. Is that then the autonomy that the clinicians have, are we losing them? Is there a conflict between human and machine? And if the human starts to work with AI, do they then become dull? And they lose their own shine of learning medical science, learning critical surgeries and all of that. Will all this go? The answer is no. Please don't even talk about it or tell your students that that someday engineers will replace doctors. That doesn't happen. Because that's a classical human skill that has been developed over 10 years, 12 years of learning. And irrespective of wherever we go with the technology, we cannot possibly go about it replacing humans. I said the same thing in a conference in Ireland 2 weeks back, and they were all over the internet. And I said, despite of all different technologies that you would use, humans will heal humans. It is not that the healing will be done by that. So what is the best way of using the technology? The best way of using the technology is to provide the human who is at the center of care, who is going to take the care about this patient with all the different information and the tools so that he can give the best possible to the sick person. That's the method, that's the way that we can actually go about in working together. I know some of my enthusiastic friends from Google and others have always gone about in publishing that the AI did better than the radiologist and all of that. Well, to an extent, from a performance of a model, you can talk about that. But in a practical use, that doesn't happen. I mean, you will have to still sign the document where the radiologists say that everything is normal with this chest X-ray. You cannot, the AI will not give its signature and say, you know, the chest X-ray is normal and people or clinicians are going to believe that and they're going to take clinical decision out of it. Not at this point of time, and looking at the crystal ball, gazing at the crystal ball, not in next 10 years. What happens in next 30 years, or some of your students would build or see, I don't know about it. And I will not talk about it because that brings in a different ethical connotation, and therefore we do not know how do we go about it doing this. But what is important here is that identify those skill gaps that are required to provide adequate training and to effectively use or build AI, and then go about it doing. What you should actually see is that when a tool is gone through all certificate regulations and all that is being governed by the organization and implemented in hospital, how do you then reduce deployment bias, where you choose not to use the tool, and therefore you stop getting the feedback data from the tool to actually go about in improving this. One of our platforms at Varsity, which is Apollo founded organization, which trains more than 1/3 of the entire doctors in India and in Middle East, does this about it, where we discuss and train doctors about use of technology in that way. The other important thing is to see how you make your solutions to integrate into different workflow, and it is to look at, I started with clinical and operational excellence, but also to look at it from a digital excellence. I don't have time, but my classes at IIM covers how you look at digital excellence from a perspective of operational backbone, shared insights, platform effects, autonomy versus alignment, and use of third party in that way. And then also look at the sixth person of perspective of this, which comes from Harvard Professor Clayton Christensen, who is no more, died 5 years back before COVID, who talked about interdependence versus modularity. And it's a very important perspective in understanding how AI adoptions are done worldwide. This is from my blackboard at the IIT Kharagpur. This is a picture that I took in the last year when I was, teaching students about optimization algorithms and how do we do the mathematics of the optimization in order to see how we go about it, building tools which would reduce capacity constraint and disability in the hospital, and see that the beds are not overflowing, patients are not overflowing, and we are able to give optimal treatment to optimal people at this time. Finally, the last concept that I would like to discuss with you is that our AI models are aging. They are aging because they face data drift, concept drift, obsolescence, because some new technology comes in, and then of course the older ones needs to be shelved, retired, sunset, put it into grave, or whatever terms that you use. So, and they also look at it from a declining accuracy, or people find it too laborious to actually work with that in that way. So you need to then go about it looking at regular monitoring, retraining, adaptive learning, and using ensemble models, robust testing and explainability over going into this. So organizations need to set up, if you are developing also, your governance over those systems when you say, enough of this algorithm, we need to now put it on a sunset and then go about doing this. At this point of time, we have 12 plus algorithms which are certified. We have 50 projects in that way. Happy to put some of your students into internship. If you look at it that, most of our interns come from our own Apollo University, but we have taken many from Indian Institute of Technology and others. They work with us. Most of our interns also get jobs in our labs. We roll it out for the fantastic interns. In fact, all the engineers who are working in my labs, at least 90% of them have been my interns at one point of time, and then they do some fantastic work of that. See, nobody can do AI all by himself or all by one organization. You have to build consortiums, foster interdisciplinary collaborations between clinicians, scientists, industry leaders. And don't go asking for data. Go for asking people about their problem statements. And once you know what their problem statements are, you do your own research and identify what that could be the possible solution. And to determine that particular solution, go into an ideation session with doctors, and then that ideation session would then spill over to a way by which you would get available data to move forward with that. That's how you're going to build these systems out, and you would be able to then do it justice to your faculties, justice to your students going forward and making things happen. With these, I'll stop here. In the interest of time, I can take a couple of questions, but if you have more questions, happy to go about them at some other time or send it through Professor Sarkar, and happy to take those questions on that.
Any questions? Any questions? Yeah, please come. So one of our faculty members having one question.
Sir, good evening. Good evening, sir.
Good evening.
Sir,
Good
my
evening.
question is that you told that service excellence and operation excellence is actually part of the quality of the accreditation, right? So Apollo is doing very well about the quality implementation project and the accreditations. So how AI will help the accreditation system in the ground level?
That's a great question, and I give you example of throughput optimization. I give you examples of how you want to break it down. So one of the most important aspect of how you break them down is to actually see in your process mapping. Now, in quality, people who have worked in quality systems, that you would know that you do a lot of process mapping where you identify value-added versus non-value-added, value-added versus non-value-added activities in this. And in that patient information flow analytics or gap analytics, you identify those non-value-added activity and then take them out in that way. Now, this is true for both clinical and operational ways to actually do this. What AI does is that go about in looking out in a predictive way for certain pathways in your system which possibly does not have adequate, meaningful or value-added steps in your systems, and then they can go about in taking them off. That's a very intense thought process, very intense way by you use AI for QI, for AI for quality improvement, and happy to have more deeper conversation around them going forward.
Okay, thank you, sir. Actually, it is very difficult to implement on ground basis because staff are not that much trained for the AI system. So, like ground level.
Yeah, but someone someday has to start it. Say 20 years back when I started the quality journey in Apollo Gleneagles Hospital at Kolkata, I faced the same problem for rolling out quality systems, which is now becoming a part and parcel of everything we do. We won't take 20 years to get AI into the system. It might take 2 years or 3 years or 4 years, but we will have to get it. There is a competitive advantage that you would get by implementing AI into your system. You have got it when you have done it for QI. Now you need to do it for AI.
Thank you, sir.
Thank you, Dr. Paul, for addressing the question. Any other question on the audience side? Okay, so sir, you mentioned one guy, Joshua, another guy, Ian Lekan. I was just hearing one of his podcasts very recently, and he said that I have lost all of my interest from LLM models. So as you mentioned that a few of the models in AI, they are in their sunset. So thank you, sir, again for joining us from your very busy schedule. You have find some time for addressing all the faculty members joined here. Thank you once again. Now I would like to request Professor Devashish Sarkar to deliver the vote of thanks to
Sujoy Kaur, thank you very much for your time. And as I have discussed that actually I have started with my research group in the mental health domain. So once you are free, come back, we'll be discussing once, and I want some of my students to work there under your guidance as an intern. And I hope they will make you happy by their dedication and their work.
I'm sure, Professor Sharkar. Thank you very much for having me. I will have to jump to one of the meetings.
Yes, yes.
But it was truly a privilege to come and address all the faculty. Thank you.
Thank you.